Before going to the disorders, a few of the terms have to be made very much familiar, because in modern diagnosis, all the dermatological conditions are addressed in terms of their lesions. Basically, the lesions have been classified into four in the name of primary lesion, like macule, papule, plaque, wheal, cyst, nodule, tumor, vesicle, bulla, and pustule. So these are all primary lesions. And when these primary lesions are passing through a very bad patch in a patient, it takes a lot of time, it takes a different course, it goes to the next level. Then, according to those clinical conditions or the clinical progress, the lesions are termed in the phase of secondary, where this basically describes about the configuration and the texture of the skin. If the first lesion group describes about the morphology or the type of the lesion, the second one is targeted on its configuration and texture, which means a scale, crust, lichenification, scar, excoriation. There are two words, especially one is exfoliation, other is excoriation, fissure, ulceration, an ulcer, erosion, and atrophy. So these are the basic lesions that we come across while we manage the skin disorder. If there is any vascular pathology associated with the dermatological condition, or the disease takes a sudden rapid change in its course, some other pathology is being suspected, then purpura, petechiae, ecchymosis, and telangiectasia are the four terminologies. And as far as the shape is concerned, a dermatological lesion can be annular or circumscribed or serpiginous or flat topped, or it's a domed shape. If at all any doubt is there, you can please raise the question in between, no problem. If at all we can answer in that course itself, I'm happy to do that, or else I can refer and tell. You can post the chat box also. Please tell.
Gopakrishna sir, sorry to interrupt. One
Okay.
of the participant has raised her hand.
Okay.
So shall we take her query?
Sure.
Okay. Dr. Safwana. Okay. We are not able to contact her.
I think that can be put on the chat box so
Okay.
that I can answer.
Okay. Okay. Okay, sir.
At last. Okay.
We'll go ahead.
Please continue, sir. Sorry.
It's okay, no problem. And when we go through the words which we discussed, let us see one by one how a macule looks like. If a skin disease comes to us in the form of vitiligo or freckle, it's usually a macule where a circumscribed area of skin which is different in color or texture from the surrounding tissue, and it is neither raised nor depressed, which means if we close our eyes and spread our fingers through the lesion, we won't feel that there is any lesion, and it is a visible lesion. It may be hyperpigmented or hypopigmented, but it is not raised nor depressed. Such lesions are called macules, and it is usually 1 centimeter or less than that. The same macule, if it is larger, that is 2 or more centimeters, we can consider that lesion as a patch. A larger macule, which is more than 2 centimeter, but it is neither raised nor depressed from the skin. It is considered to be a patch. Now comes papule. A papule is a circumscribed, palpable solid elevation of the skin which is less than 1 centimeter in size. What we come across in our clinical practice, most number of cases in the form of papule, because adverse drug reactions, warts are all belonging to those lesions. And another significant group of disorder is a papulosquamous lesion. It is usually a mixture of both. That is, it develops a reactive or degenerative epithelial component resulting in desquamation. Desquamation is that the skin will be eroded, the skin will have a discontinuity in its texture and contour. Such lesions are called papulosquamous lesion. Classical example is a case of psoriasis or any other lesions which are papular in nature, but it is widespread and it is reactive. And another lesion is plaque. A plaque is a lesion. We need not explain it. This is very common in our OP. The classical example is psoriasis, and psoriasis is the best example that we can place to explain the lesion in the terms of plaque. A vesicle, we all know, in the form of herpes simplex, or a case of pemphigus, or a case of chickenpox, or a case of measles. All these lesions which have fluid in it, but it is not much bigger in size, that is in the form of 1 centimeter or lesser is called as a vesicle, or which is larger than a vesicle is called as a bulla, which we usually term in the name of vesiculobullous lesion. In the textbook, if we see all the lesion which are fluid filled, flat, which later turns into a pustule, or which may have blood in it, or may have a serous fluid filled in it, can be considered as a vesicle if it is smaller than 1 centimeter in diameter, and if it is bigger than that, it has to be considered as a bulla. And usually a bulla or a vesicle is very fast in its onset, and it is usually seen in the cases of even in insect bites, or in the case of acid fly, which is very common in this part of the state, where its secretion itself can trigger a vesicle, which later turns into a bullous lesion, or it turns into a pustule in its normal course. Now, next lesion already I explained, it's a pustule. Chickenpox is a common example for vesicle as well as pustule, where the course of the illness makes the lesion in that way. An epidermal lesion which is usually less than 1 centimeter with visible pus inside. Classical case is acne or impetigo. Impetigo is a very common condition which comes to our practice, and it is especially seen in small children. And when a nodule is considered, nodule is, just a minute, some other doubt I think in the chat box. So, nodule is a solid mass of skin that can be seen elevated and is palpable. If we run 2 fingers across the lesion, and we try to lift that lesion from the skin, it will be movable. It will move, and it will be bigger in size. It will be soft. And the classical example is lipoma. We all know what lipoma is. And we usually tend to confuse with a sebaceous cyst and a lipoma, as well as neurofibroma. We will discuss when these respective clinical conditions comes in the later part of discussion. But usually we have a lot of confusion during our initial practice while diagnosing about lipoma or neurofibroma or a case of sebaceous cyst. They are the very common presentations that come to our OP. Wheals. Wheals means urticaria. We have already seen that a lot of lesions in our OP, we have a significant number of urticaria cases coming. It will be very fast and it will be transient. It will come and it will pass off. It's elevated and a momentary pale compressible area. It's very momentary. It comes and passes off, and there will be a small raised temperature in that area. It will be red in color usually, or a pink in color discoloration, and it is oftenly seen with a red axon and mediated flare. That is, the temperature will be raised with the reddish, soft, bulging area, and urticaria is the example. Hypersensitivity reaction type 1. And next is burrow. Now, burrow is a formation of tunnel through the passages, or it develops a passage in the skin where the parasite resides. It is usually taking abode in those burrows. Scabies is a common example. Now comes the next phase of our classification of skin lesions. Scale. Scales can be of many types, first of all. It can be silvery white, it can be briny, or a little bit discrete, which is off white in color, which sheds small powdery particles, or it can be oily in nature in the form of seborrheic dermatitis, which is usually seen in head or wherever sebum secretion is seen in the body. And it will be oily, oozing, sticky, and also odor. There will be an odor in it. And it is colored. Colored means it is having a pinkish discoloration in the form of pityriasis rosea, or in the form of carpet tack in discoid lupus erythematosus. It is very rare case. We have only got 1 or 2 cases for the past our 11 years, discoid lupus. But a very significant case, it is seen in India. But psoriasis and versicolor or rosea or seborrheic dermatitis, they are very common. So we have to be very particular in getting these terminologies. Next is crust. We had discussed a burrow. Now we are discussing about crust. It's a scab which forms in the outer layer of the skin because of drying of a skin lesion, usually a vesicle or a pustule. When the exudate dries or the hemorrhagic lesion dries and the lesion gets in a healing phase, there will be a thick detachable part of the epidermis. Such epidermis may get shed off by itself, or we have a tendency to pluck it out. Such plucking out phenomenon of a dried exudate is called crust. Chickenpox in the later phase, once the vesicle gets dried, it will shed off. Such lesions are called crust. Next comes excoriation. It is the loss of substance of skin produced by scratching. It will be linear or semilunar in shape, and it heals with scarring. Excoriation is also a common feature in a case where there is a lot of pruritus in it. Itching is very common in that presentation. Next comes lichenification. Lichenification is another sort of lesion where we can see the name itself suggests we have lichen planus in front of us, which is very common in our OP. The lesion will be thickened, hyperpigmentation will be there, and exaggeration of normal cutaneous marking. And that is because of itching. The skin and the lesion will have a linear markings in it. Alopecia, as we all know, it will be areata or alopecia totalis or universalis, where we can see a patch of area missing with hair. Hair won't be there, it will fall off. It's usually a fungal in origin. Absence of hair from normally hairy areas of the skin. Cellulitis, is a bacterial infection where there will be inflammation due to bacteria, and the area will have the features of inflammation. The features of inflammation like swelling, redness, raised temperature, or all the other features of infection. And it will be usually purulent if there is pus discharge, and the lower level of the skin will be affected, and the soft tissues may also be affected in this clinical condition. Next comes comedo, where a plug of keratin and sebum in a dilated pilosebaceous orifice. Comedo is also a cosmetological condition, and more of its remnants can be cleared by the cosmetology. Similarly, alopecia is also having a significant importance of cosmetology. Part is also very relevant here. And a cystic swelling. A cystic swelling is a closed cavity or a sac with an epithelial, endothelial, or membranous lining containing a fluid or semi-solid material. Sebaceous cyst, of course. I already mentioned about our usual confusion in our initial phase of practice, where we get confused with a case of cyst or a case of lipoma. A cyst, there is a sac beneath the skin layer, and the sac can clearly be demarcated by rolling our fingers beneath. We can see a punctum in it, which is usually the opening of that cystic swelling, and the fluid will be inside that. We have two options always in front of us. Either we have to open the epidermal layer and take the skin off, or wait by our medication to get shrunken, that lesion to get shrunken. Next lesion is erythema. Erythema is a very common terminology in all the inflammatory or infective lesions, where the vascular pathology is usually associated, the red coloration of the skin, which is due to the vascular congestion or perfusion. Now, a few things regarding blood or vascular pathologies, where purpura or ecchymosis, where the skin may be discolored because of the extravasation of blood or extravasation of RBC. Now, petechia is a punctate hemorrhagic spot, which is of 1 to 2 millimeters in diameter. Hematoma, which is little bit bigger area of leakage of vascular lesion, which is localized, which may have a tumor due to the collection of blood. Hematoma. Next comes exfoliation. We discussed about excoriation, an itchy lesion, which is due to the scratching, and the scratch marks will be there, which are linear or semilunar. But exfoliation is shedding of skin, the keratin. Epidermal skin surface will get separated in the form of scales or sheets. It may be in the form of plaques or in the form of lichenification, but the skin will get exfoliated. Dermatitis is a very common example, so as psoriasis. Sclerosis, induration or hardening of the skin as a result of fibrosis. Induration or hardening of skin. Next comes stria. It's a streak or band of a linear atrophic. This is a term that is to be seen. Atrophic, pink, purple or white lesion of the skin due to changes in connective tissue. Changes in the connective tissue. The linear markings or band will be very characteristic feature in it. Now let us see all these features. I did not add photos together with the explanation because slide number will be much more. You can see the macule. It will be hyperpigmented or hypopigmented in the layer of the skin, and a patch is a bigger macule. You can see the papules and the plaque, as in psoriasis, a wheal or raised margin in the form of urticaria, vesicle in chickenpox, pustular in herpes or chickenpox, much more bullae presentation like pemphigus or bullous impetigo, or a cystic swelling or a nodule, just as we see it's in the head, a nodule which will be hard, fixed. Its boundary, you can see the base will be uniform, and an ulcer formation, which is a discontinuity in the normal epidermis, fissure, which we see in the heels usually during the dry season, or a dry lesion, which is due to some allergic manifestation like irritant contact dermatitis due to the soap allergy or so, or in the form of scales or an atrophy. You can see that tags because of the dryness of skin, and a patch of blood in the form of purpura, or a lichenified lesion. You can see the skin thickening in between those fingers, the skin eroded in a chronic case of a skin disease with an infective or inflammatory pathology, a scar. You can see a surgical scar on the second row, third photo, the small bleeding spots in the form of petechial hemorrhages, or a case of telangiectasia. These are the few pictures. Now, next phase, I have included a few photographs. of the clinical cases because of the time